I hope that at the end of my presentation, you will be able to recognize the unmet needs in the management of GPA and MPA, be able to describe ongoing clinical trials that address these needs, and understand the direction in which the research is going in the field. So, where do we stand in 2017? We'll review that very briefly. And then we'll zero in on what the unmet needs are, and I separate the presentation into two major portions. What's the unmet need with respect to remission induction therapy, and what's the unmet need with respect to remission maintenance therapy? So just to summarize where we stand in 2017 and maybe make a couple of editorial off-the-cuff comments, based on what has been said in Dr. Langford's previous presentation. So to reaffirm, for non-severe GPA, or formerly called limited GPA, the one that we have with predominantly granulomatous disease manifestations in the ear, nose, and throat tract and the lungs, remission induction therapy with combination of prednisone and methotrexate remains the standard first treatment approach. For severe disease of GPA and MPA, however, based on the RAVE trial results, we would prefer rituximab in patients who present with a severe disease relapse, and also in those who present with PR3 ANCA, because in a subsequent exploratory analysis of the RAVE trial data, it was shown that rituximab was also superior amongst the subgroup of PR3 ANCA positive patients, whereas in MPO ANCA positive patients, it made absolutely no difference whether rituximab or cyclophosphamide was used for induction. Now, the question came up earlier, what about those patients who end up on the vent and were not included in the RAVE trial, or what about patients with severe renal disease who were not included in the RAVE trial? Couple of comments. We don't have good data on this. The data that we have are coming from cohort studies. And the cohort studies that we concluded at Mayo, the largest in alveolar hemorrhage, even amongst patients who ended up on the vent, there was a positive signal in favor of rituximab compared to cyclophosphamide. Clearly, this was not a randomized trial, but sequential patients that were treated with either or. Other data, and you can look at the references listed here, they have shown that the addition of cyclophosphamide to patients with severe renal disease may not be necessary in addition to rituximab, as suggested by the RITAZAREM study. So in my opinion, and again this is opinion based on not very strong data, but some published evidence from cohort studies, rituximab is the primary choice for PR3 ANCA positive patients, even if they have severe renal disease or even if they present with alveolar hemorrhage in respiratory failure. Now then, if they don't do well over time, we can consider adding cyclophosphamide, but that is rarely necessary in practice these days. So, for maintenance following induction with cyclophosphamide, yes, azathioprine and methotrexate are equally effective. Mycophenolate has gotten a bad rap in the only trial that compared mycophenolate to azathioprine. And I'm saying it has gotten a bad rap because we all try to understand why mycophenolate did worse in this trial compared to azathioprine. And when you look very carefully at the data and the details in the presentation, there are two things that come to mind. One is that the separation between the relapse rates in the mycophenolate arm from the azathioprine arm occurred early, and then subsequently the Kaplan-Meier lines were parallel. And when you look at the differences between the cohorts that ended up in the mycophenolate group compared to the azathioprine group, there was at first glance no difference. However, there was one notable difference, and that is that the CRP on average was significantly higher amongst the patients who ended up in the mycophenolate arm at the time of randomization or at the time of remission when they were switched to mycophenolate or azathioprine after induction with cyclophosphamide. So maybe the patients who ended up in the mycophenolate arm by the luck of the draw had a little bit less well-controlled disease, and that explains the early separation between those two drugs. So we shouldn't completely dismiss mycophenolate as a choice for remission maintenance. And the study from France, the MAINRITSAN trial, which we'll get back to at the end, has shown that rituximab is more effective than azathioprine for remission maintenance. So where are we today? After 30 years of research, after extensive use and experience with conventional agents, and after growing experience with B-cell targeted therapy? Well, clearly we're doing better. This is a study that John Stone's group from the Massachusetts General Hospital recently published, looking at population-based UK data, interestingly. And these data show that, yes, GPA still has a significantly increased mortality compared to the general patient population, although it is clearly getting better. In the recent decades, you see this on the right panel, and I don't know whether I have a pointer here or not. No, I don't have a pointer. And I don't have a mouse either. So you need to look at the right panel, and you need to not be colorblind. So you see that the early decades, the red lines, the dotted line is the normal population, the solid line is the GPA mortality. So in the early decades, 92 to 2000, there was a substantial difference. However, this gap has narrowed in the decade from 2003 to 2013. So we're doing better with more judicious use of the drugs and more timely diagnosis. These are the two major factors that have led to significant improvement in the mortality in the UK, and similarly, the hospital mortality in the US has also been on a consistent decline over the years. So this is very encouraging, but we probably still need to do better. And why do we need to do better? This is shown the mortality of GPA and MPA from a European study, combination of various clinical trials that were conducted by the UVAS group. And it shows that there is a significant mortality, and this mortality is particularly early in the time immediately following diagnosis. So there is a window of opportunity of doing better during our remission induction therapy time, when the patients still die not so much of uncontrolled disease activity, but rather of the toxicity of the treatment, particularly the infections associated with high-dose glucocorticoid therapy and intense immunosuppression. Now, this is a study from the Dutch, and this theme comes back in various forms through other publications too. And it tells us that the overall outcome of patients with GPA and MPA to this day remains determined largely by how well we can preserve kidney function early on. And if we leave the patient with substantial kidney damage, that is the key factor that subsequently affects the patient's outcome overall, and risk of ending up on renal replacement therapy. So in this study in particular, it was shown that the mortality in patients who have renal involvement and require renal replacement therapy is substantially higher than patients with renal involvement not so severe to require replacement therapy. And that whatever the patient's renal function is at 6 months really determines the long-term outcome. So we need to get to the patient fast, and we need to save as much renal function as possible, and we need to do it in a safe way. So the unmet opportunities for remission induction are really to improve the early mortality, to minimize toxicity, particularly the glucocorticoid toxicity, to minimize tissue damage, and particularly the renal damage. So this immediately brings us to the question, what is the role of plasma exchange today, and are there any novel drugs that help us to achieve these goals? With respect to opportunities in remission maintenance, it becomes quite clear that we need to individualize therapy. We need to identify the patient who's at risk for relapse, and then amongst those patients, we need to have better biomarkers that allow us to time the retreatments optimally to minimize toxicities. And maybe there are novel drugs on the horizon for that too. So the question for the audience, and this is more for entertainment value and to keep you awake. So, plasma exchange, should it be used in which of the following patients? Patients with severe renal disease with a creatinine greater than 5.6 milligrams per deciliter on presentation, patients presenting with alveolar hemorrhage, patients with serum ANCA and serum anti-GBM, in all of the above or none of the above? That's almost perfect, in all of the above. All right, well, we'll get to this and look at this based on the data that are essentially not existent to answer this question. So let's go through this. The patient with serum ANCA and anti-GBM is a patient who, based on literature, which I'm not going to show you, has a worse prognosis than the patient who is only ANCA positive. However, the serum antibody tests for anti-GBM are very sensitive but not specific. So in order to know whether the anti-GBM truly plays a role in this patient, you need to have a renal biopsy showing you linear basement membrane staining, in which case you have anti-GBM disease plus ANCA, and based on the anti-GBM disease, you should do plasma exchange. But you can't answer it based on the phrasing of the question, which only gives you the serum antibody test. So A is probably the one that has the most evidence, and we'll look at that in a minute. Patients presenting with alveolar hemorrhage, I'll show you also some evidence on that. And all of the above is always false, and none of the above is always false in this particular case too. So let's look at the evidence. The MEPEC study really has popularized the use of plasma exchange in patients presenting with severe renal damage. And in the 3 months outcome of this study has shown that there was an advantage of using plasma exchange in addition to standard glucocorticoid and cyclophosphamide therapy compared to the use of pulse intravenous methylprednisolone. In this day and age, everybody would get intravenous pulse methylprednisolone, and then we would add plasma exchange or no plasma exchange. So the trial design of the MEPEX trial that showed a clear positive signal in favor of plasma exchange versus methylprednisolone may not be all that applicable in this day and age. But when we looked at the long-term data, Michael Walsh and David Jane looked at the long-term outcomes data of the MEPEX trial, and that showed us that further out than 1 year from the start of the trial, there was really no difference in major outcomes compared between the two groups. So with that long-term data, the enthusiasm for plasma exchange has waned a little bit in this patient population, and it opened the door for the Pexivas study. And we'll get back to the Pexivas trial in a moment. The issue of using plasma exchange in patients with alveolar hemorrhage who end up in the intensive care unit was first highlighted by the Chapel Hill group in 2003 when they reported on 20 patients who entered the ICU with microscopic polyangiitis-related alveolar hemorrhage. And in this series of 20 patients, everybody received methylprednisolone and plasma exchange, and everybody did well. And this contrasted, of course, with previous reports from patients that ended up in the ICU with alveolar hemorrhage and glomerulonephritis from other centers, which had a higher mortality. And based on that, there was very quickly some enthusiasm for plasma exchange amongst physicians treating these patients. However, when we looked retrospectively at our alveolar hemorrhage cohort of 73 patients last year, we found no advantage of plasma exchange over not plasma exchange, even when the outcomes were adjusted for the severity of the patient's disease. And when you summarize all the available literature that tells us something about the outcome of diffuse alveolar hemorrhage during the hospitalization and the survival of the patient in alveolar hemorrhage due to ANCA-associated vasculitis, and you add it all up, you don't get a very clear picture pointing into the favor of a plasma exchange. To the contrary, you walk away with saying, well, maybe plasma exchange really makes no difference in this patient population. Now, you have to take these data and the summary of data with a grain of salt, because with the exception of our study from Mayo Clinic, we really have no way of adjusting for the severity of the patients who ended up on plasma exchange versus who didn't end up on plasma exchange in these publications. So based on all we know in patients with alveolar hemorrhage, I still don't know whether I should use plasma exchange or not in these patients, and it often comes down to very individual decision-making at the bedside, where we say, well, we don't really know whether it helps, but we'll rather try it now if things are not going well, rather than having later on to say, well, maybe we should have. So we need data, and hopefully we will get this data soon, because the Pexivas trial that compares plasma exchange to no plasma exchange in a randomized fashion in patients with severe ANCA-associated vasculitis has recently completed enrollment. It's the largest trial that is conducted under the leadership of David Jane and Peter Merkel. It's a global trial funded by tax dollars in Europe, in the US, in Australia, New Zealand, and Japan, and essentially a global trial that enrolled 700 patients. It's the largest trial in ANCA-associated vasculitis that will give us answers to several questions. First of all, it will address the question whether plasma exchange is of benefit in patients with severe renal disease and or alveolar hemorrhage, and it will also address the crucial question of whether we can get by with less glucocorticoids during the remission induction phase, as we have customarily been doing, because in a factorial design in this trial, the patients are also randomized to a standard prednisone tapering regimen versus a more accelerated steroid tapering regimen. So we're hoping to get answers to these crucial questions shortly. Another question here: which of the following drugs are currently not under investigation in ANCA-associated vasculitis? Abatacept, avacopan, rituximab, prednisone, or a PET4 inhibitor? Well, actually, number E, or number 5, is the correct answer. There is actually a prednisone trial going on, the TAPIR trial, which compares low-dose prednisone for long-term maintenance versus tapering to 0. The Abrogate study, which we'll get to, looks at abatacept in patients with non-severe disease relapses. Avacopan is the new kid on the block that we'll talk about, and rituximab for maintenance is still under investigation in the context of the RITAZAREM trial. So what about novel drugs? Well, for remission induction, the goal really is to get by with less steroids or maybe with no steroids. And in order to do this, we need to effectively target the innate immunity, because it seems that the innate immunity is really what is causing most trouble in the very acute phase of the disease, with lots of neutrophil activation and neutrophil-mediated damage. And we have a promising new agent on the horizon from this that is undergoing a phase 3 trial study that is starting right now as we speak. And the enthusiasm for this drug really was originally generated by animal models that came from the Chapel Hill group. And their MPO-ANCA transfer model, which showed us that ANCA plays a significant pathogenic role in the development of capillaritis, and particularly MPO-ANCA capillaritis. These studies showed us that the complement system is involved in the way ANCA activate neutrophils and lead to tissue damage. They were able to prove that the lesions in this mouse model were dependent on complement, that the intact alternative pathway was required, and that mice lacking the C5a receptor on neutrophils did not develop the disease, and that a monoclonal antibody blocking C5a could be used therapeutically in these mice. And then when a small molecule became available that specifically inhibited the C5a receptor on human neutrophils, the company, in a very, I should say, daring way, moved forward to two phase 2 trials, the CLEAR trial and the CLASSIC trial. And the data of the CLEAR trial have been announced in abstract form as well as in a press release. They're not published yet. They should be published anytime. And these data showed a very encouraging safety signal, meaning there were no unanticipated adverse events. And it also showed a very encouraging signal in terms of being able to put patients into remission swiftly, even without glucocorticoids. And the CLASSIC trial has also been completed, and the understanding is that, based on what we've heard from abstract presentations, is that there was no negative adverse event signal in that trial. The drug was given in comparison to placebo in addition to standard therapy. So overall, these phase 2 trial signals have been so promising to allow the company to move forward with a label-enabling phase 3 trial that compares this new agent that is called avacopan in direct comparison to placebo versus prednisone to placebo, in addition to either rituximab or cyclophosphamide for remission induction in severe disease. So it's a head-to-head comparison of prednisone versus avacopan without any prednisone, in addition to rituximab or cyclophosphamide for induction of severe disease. So this would be a major breakthrough if it really comes to pass, and it would allow us, hopefully, to, in the future, treat remission induction without high-dose glucocorticoids and all its associated toxicities. So what about some other approaches that might come to pass down the road? Again, focusing on the pathogenesis of the acute phase of the disease, recent interest has been brought to the so-called field of netosis, or net formation. Neutrophils form extracellular traps, and this is a mechanism that allows us to fight infections. It's been recognized more than 10 years ago now, and this net formation is also occurring in the acute phase of ANCA-associated vasculitis. Net formation is increased in patients by neutrophils from patients with active disease compared to controls or patients in remission. And these nets can actually be documented in the kidney lesions. And If we summarize what we know about NET formation and ANCA-associated vasculitis, it seems that ANCA induce a vicious cycle of self-perpetuated NET formation. These NETs do occur in the absence of infection in patients with ANCA-associated vasculitis. They can activate plasmacytoid dendritic cells, and these NETs contain PR3 and MPO, where they are again accessible to ANCA, and it's been shown separately that chromatin immunoglobulin complexes, or NETs with bound ANCA, can induce loss of tolerance and autoantibody production in a TLR9-dependent manner. And one of the most potent inducers of NET formation is Staph aureus. So if we can target NET formation therapeutically, maybe we can ameliorate the acute phase of the disease. The NET formation has also been implicated in thrombosis, and as we all know, patients with active ANCA-associated vasculitis have a substantially increased risk for venous thromboembolism. So I think the community might start taking a look at PAD4 inhibition, which has been shown to be able to interfere with NET formation. So with that, I'm going to switch from the acute phase of the disease and remission induction and what might be on the horizon to what the opportunities are in remission maintenance. It was mentioned briefly that there is a substantial difference in relapse risk between MPO ANCA-positive patients versus PR3 ANCA-positive patients, and the RAVE trial has borne this out the same way as many other studies. The group from Chapel Hill has shown the same phenomenon in a different context, and again, patients with PR3 ANCA are at substantially higher risk than patients with MPO ANCA in every various permutation you look at this. So for remission maintenance efforts, maybe we should emphasize the PR3 ANCA positive patient and maybe not focus so much on the MPO ANCA positive patient. And clearly in remission relapse trials or remission maintenance trials going forward, we should separate these patients out, or at least stratify as we're currently doing, but then make sure that we have enough MPO ANCA patients to, from our sample size calculations and power calculation perspective, to make a reasonable statement about these patients at the end of the day, rather than diluting our patient populations with MPO ANCA positive patients. So there again, we're looking at targeting the adaptive immunity with our agents when we talk about remission maintenance, and we're targeting B cells and we're targeting T cells, and there's a good rationale for this, and this goes back to old studies that have pointed towards the activity of B cells as being directly linked to the disease activity, but there is a lurking background abnormality of T cell activation that persists even during remission and probably represents the key to the chronically relapsing nature of PR3 ANCA positive patients. So we can target remission maintenance by keeping the B cells out of the way, or we can target remission maintenance by addressing the abnormal T cell function by inhibiting co-stimulation, preventing full T cell activation, as we're doing with Abrogate. Abrogate is a new trial looking at the role of abatacept, inhibiting co-stimulation and complete T cell activation with this agent in patients with GPA. There is a phase 3 trial that is currently recruiting for patients with relapsing non-severe GPA. And this phase 3 study is based on the encouraging signal that we got from a phase 2 study that was completed under the leadership of Dr. Langford, who is also the PI on the phase 3 study that is currently going on. And in the phase 2 study, 90% of patients had disease improvement with abatacept, 80% achieved remission, 20% relapsed, and I guess my time is up, so all right, we'll come to a close quickly. So rituximab is effective for maintenance. That's been shown by the RITAZAREM trial. That was already mentioned. I won't spend a whole lot of time on it. To avoid one event, 4 patients had to be treated with rituximab in this trial. A recent study that was published at the ANCA meeting in Tokyo, and probably one of the most exciting presentations at the ANCA meeting in Tokyo, actually reported on an economic evaluation of the MAINRITSAN study, and it showed that rituximab was indeed cost-effective. The higher drug cost was offset by a higher relapse rate in the azathioprine arm and higher renal damage occurring in the azathioprine arm as a result of the relapses. And the incremental cost-effectiveness ratio was 259 euros per avoided relapse. Now you can say this is European healthcare system, everything is cheaper, but yes, the drug is cheaper over there, but then everything else is cheaper, including all the treatment of the relapses and everything. So if we did this calculation in this country, we would probably come up with similar results. The RITAZAREM study currently addresses the issue of what to do after remission induction with rituximab. The MAINRITSAN trial only looked at patients who had remission induced with cyclophosphamide. In contrast to the MAINRITSAN study, which used 500 milligrams every 6 months, the RITAZAREM trial uses 1 gram every 4 months. And that is because some patients have relapsed early in that 4 to 6 months window in previous cohort studies. The enrollment of the RITAZAREM trial has been completed. We're awaiting the results in about a year from now. So last question, and then we come to a close. Which statement about serial PR3 ANCA testing is appropriate? It should not be done because it has no predictive value for relapse. It is most useful in patients who had remission induction with cyclophosphamide followed by maintenance with azathioprine or methotrexate. It's most useful in a patient with GPA who had a relapse with lung nodules and ENT disease while on methotrexate maintenance. It's most useful in a patient who received rituximab after presenting with alveolar hemorrhage and glomerulonephritis. Okay, 28% of you must be living in Cleveland. D is the correct answer. It's most useful in patients who received rituximab after presenting with alveolar hemorrhage and glomerulonephritis. Well, it's all a matter of which patient do we expose to how much toxicity from maintenance therapy. In the olden days, we could effectively keep patients in remission with cyclophosphamide, but the toxicity by far outweighed the benefits. In this day and age where we use rituximab, the balance may be shifted, but still we may be in a position of not having everybody needing to be retreated every 6 months. We can possibly individualize this if we have the right biomarkers that allow us to tell which patient is at risk if they are falling into the group of PR3 ANCA positive patients who are relapsing or at high risk of relapse. So listen to the patient. First of all, the VCRC study has shown that patients can tell when their relapse is coming on. And in this longitudinal studies, the patient's global assessment went up on average 1 visit prior to the physician being able to detect the relapse and score it on the BVAS score. So we should never dismiss when a patient says, I'm getting these symptoms back, I think I'm going to relapse. We need to look harder, and we need to have better biomarker than we currently have to really detect that impending relapse. ANCA and B cells can potentially do this in chronically relapsing PR3 ANCA patients, and we at Mayo have used this to individually time the retreatment with rituximab in patients. Usually we don't see severe relapses before the B cells return. So we wait for the B cell return, and then we want to know what the PR3 ANCA level does. And when it increases, then we retreat patients, and we're able to prevent relapses in that fashion. The MAINRITSAN 2 study has formally compared these two approaches, the one of individually timed retreatment versus the every 6 months treatment, and they showed the same efficacy, fewer rituximab infusions, same adverse events, but they found that in their study, ANCA was not helpful. So the final word is out. We have to see the final publication from that trial. So what about serial PR3 ANCA testing? In the RAVE trial, we looked at factors that determine the clinical utility for relapse prediction analyzed in the RAVE trial. And the risk of relapse following a PR3 ANCA rise really depends on methodological issues. So that's not very helpful for day-to-day clinical practice, unfortunately, but that's the reality. It also depends on the disease phenotype at baseline. It is most useful in patients who present with disease manifestations driven by capillaritis, patients with renal involvement, and patients with alveolar hemorrhage. And that has also been borne out by a study coming from the Netherlands. And last not least, it seems to be most significantly useful in patients who've had remission induction with rituximab, and it does not seem to work well for patients who have been treated with conventional agents. So, new kid on the block, and that's just a peek in the future. We can now detect PR3 ANCA expressing B cells, and I'd like to draw your attention to the lower two right panels. With these PR3 ANCA expressing B cells, we found that they are higher in patients compared to normal controls, and they are higher in patients with active disease than in patients in remission. And they are particularly higher in patients with active disease compared to those in remission where the PR3 ANCA levels are at the same high elevation. So where the PR3 ANCA levels may not help us, maybe in the future the PR3 ANCA expressing B cells as markers of relapse may help us, and this is currently under investigation again in the context of the RAVE trial for validation. So in summary, glucocorticoid avoidance is the primary focus of clinical research in GPA and MPA. Lower dosing regimens, almost no glucocorticoids, more effective remission maintenance in order to avoid re-exposure need from remission induction therapy. Better targeted remission maintenance are all the focus of research currently. The innate immunity is the target of new drugs for remission induction, whereas for maintenance, we still focus on targeting the adaptive immunity. Thank you.